We tend to focus on, the really dramatic medical interventions, but have you ever stopped to think about the surprisingly intricate world behind something as seemingly simple as a wound?
Right. It's way more complex than most people realize.
It really is. It turns out what happens after that initial injury, well, it's governed by a really complex set of rules.
Absolutely. And for us here in the United States, that complexity really shows up in the form of, well, extensive regulations and how healthcare providers actually get paid the whole reimbursement landscape.
Mm.
And that's precisely what we're unpacking today. Our insights are coming from wound care essentials, practice principles, and also a really informative chapter specifically on reimbursement regulations impacting wound care.
Okay. So our goal for you today is really to try and demystify this system a bit. We want to get a handle on who pays for wound care, the methods they use, and importantly, why these regulations matter so much.
Yeah.
I mean, it's not just about the dollars and cents, is it? It's about making sure people get quality care and also managing costs effectively, for everyone involved.
Exactly. And, as our sources clearly point out, these chronic, non-healing wounds, they have a massive economic footprint, especially on programs like Medicare.
Huge.
We're talking tens of billions of dollars every single year. So grasping this landscape, it isn't just some academic exercise. It has really tangible consequences for patients and, frankly, the entire healthcare system.
Okay, let's dive right in then. Regulations, I know they might sound a bit dull on the surface,
Uh-huh.
but our sources really emphasize just how much they shape healthcare in the U.S., particularly when we're talking about wound care.
Yeah, what's really interesting is that these regulations, they essentially define who gets access to wound care and the level of care they actually receive.
Right.
And while, healthcare professionals might sometimes feel kind of burdened by all these rules, they do play this vital role in ensuring standards are met and promoting safe healthcare practices pretty much across the board.
So who's actually setting all these rules? Is it just like one big government agency pulling all the strings?
Oh, not at all. It's really a multi-layered system. You've got regulations coming from federal agencies, state governments, even local authorities sometimes.
Wow. Okay.
And then on top of that, you have accreditation organizations. Now, participation with them is often voluntary, but getting accredited, it really signifies a commitment to certain quality standards.
And what's the sort of ultimate aim behind all this regulatory oversight in wound care? What's the big picture goal?
Well, the core objective is kind of twofold. First, it's about making sure that everyone who needs high-quality wound care can actually get it,
Yeah.
especially those who are most vulnerable, like, the elderly population.
Mhm.
And second, it's about trying to control the, well, ever-increasing costs of healthcare. It's this constant balancing act, really.
Yeah, I can imagine. Our sources also highlight different tools the government uses to actually implement these regulations. Can you give us a few examples?
Certainly. So the government uses several regulatory levers, you could say. These include things like setting entry requirements for healthcare professionals, that's licensing.
Okay.
They also define payment methodologies, which basically dictates how care gets reimbursed. And then they establish quality controls, all aimed at improving the standards of care that are provided.
Gotcha. Now let's talk about who's actually footing the bill here. Our deep dive points to government payers as a really, really significant piece of this puzzle, with a particular focus on Medicare and Medicaid.
That's absolutely right. I mean, while there are many different entities that pay for health care, private insurance, unions, employers, Medicare and Medicaid, which are both managed by the Centers for Medicare and Medicaid Services, or CMS, they're really central.
Right.
And because CMS provides such substantial funding to states for health care, state Medicaid programs generally have to, fall in line with federal regulations.
And it sounds like it's absolutely critical then for doctors, nurses, everyone involved to understand the distinctions between these two programs, even before they start mapping out a treatment plan.
Oh, absolutely essential. What's covered, who qualifies, how much gets reimbursed. It can differ quite a lot between Medicare and Medicaid.
Mm-hmm.
Knowing those specifics up front is just key for effective treatment planning. Plus, as we learn from our sources, private insurers often kind of look to Medicare's coverage decisions when they set their own policies.
So they sort of follow Medicare's lead.
Often, yeah. So let's zoom in on Medicare first. What are the key things we really need to understand about this federal program?
Okay.
Well, Medicare, it started way back in 1965. It primarily serves people who are 65 or older, but also younger folks with certain disabilities or end-stage kidney disease.
Right.
And just to give you a sense of scale, back in 2017, it covered over 55 million people, and its total spending hit a pretty staggering $705.9 billion.
Wow. That's a huge number. And it's funded through different pots of money, isn't it?
Okay.
It's not just one source.
Exactly. There are two main trust funds. You've got the Hospital Insurance Trust Fund, which most people know as Part A.
Mm-hmm.
And then there's the Supplementary Medical Insurance Trust Fund, or Part B. Part A generally covers things like inpatient hospital stays, care in skilled nursing facilities, hospice services, and some home health care, too. And it's mainly funded through payroll taxes.
Okay. And Part B, what does that cover?
So Part B covers things like doctor services, outpatient hospital care, and, other medical services. Back in 2019, the standard monthly premium was around $135.50. And it's funded through a mix of those premiums paid by beneficiaries and general federal tax revenue.
Got it.
Oh, and it's also worth noting, while Medicare has Part D for prescription drugs, right now it doesn't specifically cover most wound care products under that particular benefit.
Okay.
And we also can't forget Medicare Advantage, which offers options for people to enroll in managed care plans instead of traditional Medicare.
Okay, that's a helpful overview of Medicare. Now, how does Medicaid compare? What are the main differences we should know about?
Well, Medicaid, which also started in 1965, is actually a joint program. It's funded by both the federal government and the states.
Oh, okay.
Its primary goal is to provide health care coverage to the poorest Americans. The big difference here is that while the federal government sets some broad rules, each individual state actually runs its own Medicaid program.
So that means there could be quite a bit of variation depending on which state you happen to be in.
Exactly. Huge variation sometimes. Each state gets to decide things like which specific services are covered, how much of those services are covered, who is eligible to receive them, and even the rates at which healthcare providers get paid.
Wow.
This can lead to pretty significant differences in what wound care treatments and supplies are covered and, how often they can be reimbursed. For example, how frequently a doctor can get paid for, say, debriding a wound, cleaning out the damaged tissue that can vary quite a bit from state to state.
Right. And then we have managed care organizations, or MCOs. Where do they fit into this whole picture?
MCOs are basically organizations that aim to provide healthcare services while also trying to manage the costs. They sort of bring together the payment side with efforts to control costs and ensure quality.
Okay.
Typically, they receive a fixed amount of money, like a premium or what's called capitation for each person enrolled, and that's meant to cover a specific set of health benefits.
Mm-hmm.
But the specific services they offer for patients who have wounds, well, that can vary quite a bit depending on the particular MCO.
Okay. Earlier, you touched on the significant financial burden that chronic wounds place on Medicare. Let's maybe dig a little deeper into those numbers.
Yeah, it's pretty striking. A 2018 study published in Value in Health really highlighted this. Looking at Medicare data from back in 2014, they estimated that around 15% of Medicare beneficiaries, that's about 8.2 million people, were dealing with chronic wounds that weren't healing properly.
15%. That's much higher than I would have guessed.
It was much higher than previous estimates, yeah. And the estimated cost...
Let me guess.
Huge.
Astronomical, really. The total annual Medicare spending just on all types of wounds ranged from $28.1 billion up to $31.7 billion.
Billion with a B.
With a B. And what was particularly interesting was that infected surgical wounds, or surgical wounds that had reopened, they had the highest cost per wound. And most of the spending was actually for care provided in hospital outpatient settings.
So a shift away from inpatient stays for this.
Exactly. It suggests a trend towards managing these wounds outside of the traditional inpatient hospital setting.
So this isn't just a small dent in the Medicare budget we're talking about.
Not even close. And this really underscores, the critical need for more research funding at the federal level, better ways to actually measure the quality of wound care, and reimbursement systems that actually make sense for this specific type of care.
Right. Our sources point out that current payment policies from CMS, including things like the Medicare Access and CHP Reauthorization Act, or MAC-RA, they don't really adequately address these specific needs yet.
So it sounds like really good tracking and documentation showing how many people have these chronic wounds and how much it's truly costing that's essential to push for these kinds of changes.
Absolutely. Demonstrating the true scope of the problem to CMS and policymakers, that's crucial if we want to develop better quality standards and more appropriate reimbursement models specifically for wound care.
Okay. Now, let's shift our focus a bit to the basic principles of how wound care actually gets paid for. Our sources emphasize that the way providers are reimbursed, it directly affects how they deliver care.
That's a really, really key point. Payers, whether it's Medicare, Medicaid, or private insurers, they're increasingly looking very closely at where their money is going. And they're demanding evidence that patients are actually getting better to justify the payments they make. So clinicians who can thoroughly document how they assess wounds, what treatments they provide, and the results of those treatments, they're much more likely to actually receive payment.
And while the ideal, of course, is always to provide care based on the best available evidence,
Right.
the reality for healthcare professionals can vary quite a bit depending on where they work and, importantly, who's paying the bill.
Exactly. And Medicare reimbursement in particular, it isn't just about getting paid for doing something. It's really this three-part process. It involves coding, coverage, and payment.
Okay, 3 parts.
And each of these operates somewhat independently. So just because a service has a specific billing code doesn't automatically mean Medicare will cover it. And even if it's coded correctly and it is covered, the actual payment amount isn't necessarily guaranteed either. Coding and coverage tend to be pretty universal across different settings, but the payment part, that's often very setting specific.
Okay, so let's break down those 3 parts then, starting with coding. What kinds of codes are we talking about here?
Okay, there are a few main coding systems we need to be aware of. First, there's the Healthcare Common Procedure Coding System, or HCPCS, often pronounced HCPCS.
Okay, HCPCS.
Yes. Within that, you have Level I codes. These are also known as CPT codes, current procedural terminology. They're used to report procedures performed by clinicians like physicians and nurse practitioners.
Right.
These codes are pretty universal across different payers, but the amount they'll actually pay can vary depending on the profession of the person providing the service. So, for example, CPT code 11-Velar-42 is used for debridement, the removal of damaged tissue down to the subcutaneous layer.
Got it. And what about HCPCS Level 2 codes? What are those for?
Level 2 codes are alphanumeric, so they use letters and numbers. They primarily represent things like medical supplies, durable medical equipment, think wheelchairs or hospital beds, non-physician services, and items that aren't covered by those level ICPT codes. This bucket includes what's known as DMPOS, durable medical equipment, prosthetics, orthotics, and supplies.
DMPOS. Okay.
Yeah, so that covers things like ambulance services, prosthetic devices, but also cellular and tissue-based products used on wounds, often called CTPs, or sometimes skin substitutes.
Oh, okay.
It also includes surgical dressings, support surfaces like specialized mattresses, and negative pressure wound therapy systems.
Okay. What about DRGs and ICD-10 codes? We hear about those too.
Right. So diagnosis-related groups, or DRGs, those are specifically used for claims submitted by inpatient hospitals. They basically group patients who are likely to need similar hospital resources, which helps in predicting costs. Then we have the International Classification of Diseases, ICD-10. These are the diagnosis codes used for pretty much all patient encounters. And with over 68,000 codes, it's way more specific than the older ICD-9 system we used to use.
Way more.
Yeah. For pressure ulcers, for instance, the ICD-10 codes specify not only the location and the stage of the ulcer, but also whether it was present when the patient was admitted to the hospital, that POA status we mentioned.
Okay, that's coding. Now let's tackle coverage. What does that actually mean in this context? Is it just whether insurance pays?
Well, coverage essentially refers to whether a particular service or procedure or medical device, drug, or supply falls under a defined medical benefit category according to a specific health plan.
Okay.
And this can vary quite a bit depending on the type of insurance, Medicare, Medicaid, private, the setting where the care is being given, and the individual patient's medical condition.
Right.
And even if a service or product could potentially be covered, payers often have specific coverage policies. These policies outline the exact criteria that must be met.
Like what kind of criteria?
Things like the patient's specific medical conditions, their diagnosis, the specific billing codes that need to be used, and any particular requirements or limitations on that coverage.
And where exactly can wound care services be covered? It's not just limited to hospitals, is it?
Oh, no, not at all. Wound care can be covered in a whole range of settings. You've got inpatient hospitals, outpatient hospital clinics, long-term care hospitals, specialized outpatient clinics like dedicated wound care centers, doctor's offices, skilled nursing facilities, and even in the patient's own home through home healthcare services.
Okay. Now, our sources mentioned that Medicare doesn't actually have a lot of national coverage policies specifically for wound care products.
Yeah.
So how is coverage usually determined then?
That's correct. For the vast majority of wound care products and procedures covered by Medicare, the coverage decisions are actually made through what are called local coverage determinations, or LCDs, and also related policy articles.
LCDs, local coverage determinations.
Exactly. And these are developed by the Medicare Administrative Contractors, or MACs.
Yeah.
These are the companies that process the claims.
Denies.
Right. So the MACs that handle traditional Medicare Part A and Part B claims, the AB MACs, they create policies for things like those cellular and tissue-based products, CTPs, disposable negative pressure wound therapy, and debridement procedures.
Okay.
On the other hand, you have the durable medical equipment, MX, or the DMX. They develop the policies for all that DMPO stuff, dressings, NPWT pumps, compression devices, support surfaces.
Got it. So it's split between different types of MX.
Precisely. Now, there are a few national coverage determinations, NCDs, for specific things like hyperbaric oxygen therapy and topical oxygen, but most of the action is at the local level with the LCDs. And all these policies, you can usually find them on the official CMS website and the websites of the specific MX.
So these MX, these Medicare Administrative Contractors, they sound like really crucial players in the whole Medicare system. Can you tell us a bit more about what exactly they do?
They really are. MSCs are essentially private insurance companies that Medicare contracts with to process claims for beneficiaries who are in the traditional fee-for-service Medicare program. They operate within specific geographic regions. They act as the primary operational link between Medicare and the healthcare providers. But they do a lot more than just process claims. They also handle payments to providers, manage provider enrollment in Medicare. They conduct audits to make sure billing is correct. They manage the appeals process if claims get denied, respond to inquiries from both providers and beneficiaries. They educate providers on Medicare rules, develop those crucial LCDs we just talked about, and they even review medical records to ensure services were medically necessary.
Wow, they wear a lot of hats.
They really do. They serve a huge number of providers, over 1.5 million, process billions of claims each year, and pay out hundreds of billions of dollars in benefits. It's a massive operation.
And the DMACs, the ones focused on durable medical equipment, they have a more specific role within that.
Yes, exactly. The DMACs are specifically responsible for administering the Medicare claims for suppliers of durable medical equipment, prosthetics, orthotics, and supplies that DMES category.
Right.
They're the main contact for those suppliers. Beneficiaries usually interact with beneficiary contact centers for DMEPO's claim questions. There are currently 4 DMACs, each covering a specific part of the country, and they're the ones who define those local medical coverage policies for DMEPO's items. And it's important to remember, for covered DMEPOs, beneficiaries typically have to meet their annual Medicare Part B deductible first, and then they're usually responsible for paying 20% of the cost as coinsurance.
Okay. Our sources give us some specific examples of these coverage policies for different wound care products. Let's talk about negative pressure wound therapy, for instance. What are the general rules there?
Sure. For negative pressure wound therapy pumps and the associated supplies to be covered under Medicare Part B, the patient generally needs to have a chronic wound that fits certain criteria. This could be a stage 3 or 4 pressure ulcer, a diabetic foot ulcer, a venous leg ulcer, an arterial ulcer, or maybe a chronic ulcer with multiple causes that's been present for at least 30 days.
Okay, so specific types of wounds.
Right. And the DMEMICs require pretty extensive documentation before they'll approve coverage. So it's really, really important for clinicians to review the specific coverage policies in their particular region. The details matter.
What about support surfaces? Things like specialized mattresses designed to prevent pressure ulcers. How does that work?
Medicare Part B also covers support surfaces, yes. And CMS actually categorizes them into 3 different groups for reimbursement. Group 1 includes your basic pressure-reducing pads and mattresses.
Yep.
Group 2 covers more advanced options, things like powered mattress overlays or advanced non-powered mattresses.
Yep.
And Group 3 is specifically for air fluidized beds, which are highly specialized. And again, like with MPWT, there are very specific criteria outlined in the LCDs and policy articles that must be met for Medicare to reimburse for these. You have to check the local rules.
And what about more common items like, say, surgical dressings? Are those typically covered?
Yes, surgical dressings are typically covered under the surgical dressing benefit when they're used in outpatient settings, like a hospital outpatient wound clinic or in a physician's office. The coverage for these is generally determined by the DMEMICs.
Okay, and let's take one more example. Pneumatic compression devices. When might those be covered?
These devices are typically covered when they're used to treat patients who have chronic venous insufficiency complicated by venous stasis ulcers, or sometimes for treating lymphedema.
Hmm.
Reimbursement is based on pretty detailed coverage criteria that are outlined in the relevant local coverage determination, the LCD. So again, you need to review those specific guidelines to see if a particular patient qualifies.
We also mentioned the ABM facts earlier, the ones handling parts A and B. What specific role do they play in setting coverage policies, especially for things like those CTPs?
Right. The AB Maxis handle the broader administrative tasks for traditional Medicare Parts A and B. Now, they have to follow any national coverage determinations, the NCDs that CMS issues.
Okay.
But they also have the authority to develop their own local coverage determinations, the LCDs, when the national rules are maybe a bit vague or simply don't exist for a particular service or product.
So they fill in the gaps.
Exactly. And crucially, the coverage policies for those cellular and tissue-based products used in wound care, the CDPs, those are managed by these ABMXCs within their specific geographic areas through LCDs.
So that means the rules for CTPs could be different depending on where you are in the country.
Yes, potentially quite different. The coverage rules can vary significantly from one MMAXC jurisdiction to another, and the same thing applies to LCDs related to disposable negative pressure wound therapy and even debridement procedures. You can see inconsistencies across jurisdictions.
Wow.
So it's just absolutely vital for clinicians to be aware of and actively review the local policies that apply in their specific area. You can't assume the rules are the same everywhere.
Okay. So to kind of summarize the coverage landscape then, it's a very localized, often intricate system. It really requires healthcare providers to stay constantly informed about the specific rules in their particular neck of the woods.
Precisely. It's complex. Now let's move on to that third key component of reimbursement.
Yeah.
The actual payment itself. How does Medicare actually go about paying providers once something is coded and covered?
Our sources indicate that the method of payment can vary quite a bit. Sometimes it's a bundled payment, other times it's more itemized, depending on where the care is being provided.
Exactly. A global or bundled payment is designed to cover all the services needed to treat a specific condition during a particular episode of care. This approach is often used for inpatient hospital stays and sometimes for outpatient hospital discharges too. Itemized payments, on the other hand, are for individual services, like a specific doctor's office visit or a particular procedure. And as we noted earlier, the payment method is often determined more by the setting where the service is delivered rather than the specific service or item itself.
We're going to delve into how payment works in specific healthcare settings a bit later, but before we do that, there's been this really significant shift happening in how clinicians themselves are paid, moving away from that traditional fee-for-service model.
Yes, that's a huge development. We're seeing this move away from a system where healthcare providers were primarily paid just for the sheer volume of services they provided, regardless of the outcome.
Right, quantity over quality sometimes.
Exactly. Towards a system that increasingly emphasizes the value and the quality of the care delivered. While fee-for-service is straightforward, it could sometimes create incentives for, potentially unnecessary tests and treatments.
And the major catalyst for this big change was the Medicare Access and CAT Reauthorization Act, or MACRA, which was passed back in 2015.
That's correct. Medicare did away with the old, unpopular sustainable growth rate formula and really ushered in this new era focused on value-based payment. Starting in 2019, physicians basically had a choice between two main payment pathways under MACRA.
Okay, and what are those two pathways?
The first one is called the Merit-Based Incentive Payment System, or MMICS. Now, this system still has elements of fee-for-service. Physicians are still paid based on a fee schedule for individual services. But they can also receive bonus payments or, conversely, face penalties based on their performance in several key areas. These include the quality of care they provide, how efficiently they use resources, their adoption and meaningful use of electronic health records, and their participation in activities aimed at improving clinical practice. It essentially rolled several older Medicare incentive programs into one single system.
Okay, that's MIPS.
Yeah.
And the second pathway.
The second pathway involves significant participation in what are known as alternative payment models, or APMs. Right. Unlike traditional fee-for-service, APMs are designed to reward healthcare providers for the quality of care they deliver. They focus on things like improving patient health outcomes, delivering high-quality care, improving overall population health, and lowering costs rather than just the number of procedures performed.
So it's really about managing health, not just treating sickness.
Exactly. It's about effectively managing the health of individual patients and, in some cases, entire populations. It shifts the focus.
And it sounds like these EPMs are becoming more common now.
They definitely are. By 2017, something like 34% of all healthcare payments in the U.S. were tied to these value-based models in some way. These can range from basic fee-for-service arrangements that just have some links to quality metrics, all the way to more integrated population-based payment systems.
Hmm.
This shift really requires a much more collaborative and coordinated approach to patient care. It necessitates teamwork among all the different healthcare professionals involved in a patient's treatment journey.
Throughout our discussion today, the importance of documentation has come up again and again. Our sources really stress that accurate and thorough documentation is absolutely key for getting paid in this system.
Oh, absolutely. You really can't overstate it. Comprehensive and accurate documentation is truly the foundation for successful reimbursement, both for the healthcare services provided and for any medical products used.
Right.
Whether it's documenting the specifics of a debridement procedure, the application of one of those cellular and tissue-based products, or simply noting whether a pressure ulcer was present when a patient was admitted to the hospital, that meticulous record keeping is just crucial. Regulatory agencies have very specific requirements for what needs to be documented, and these must be followed carefully.
Why is it so critically important? What happens if the documentation isn't there?
Well, thorough documentation provides the justification, the proof, for why the services and products provided were medically necessary, whether it was for preventing a problem or treating an existing one. Without that clear justification documented in the medical record, healthcare providers face a pretty significant risk of having their claims denied or having their reimbursement withheld entirely. And CMS is also actively encouraging the use of electronic health records, EHRs, partly to improve the quality and accessibility of documentation for both patient care and for quality measurement purposes. They even offer financial incentives for adopting and meaningfully using EHRs.
And our sources even include a specific table outlining the essential elements of good wound documentation.
Yes, and it's also really important to reiterate that those local coverage determinations, the LCDs issued by the ABMX for things like debridement and CTPs, and also the LCD issued by the DMEX for DMPOS claims, which covers dressings, MPWT, compression devices. All of those have very specific and mandatory documentation requirements that absolutely must be met to secure coverage and reimbursement. No documentation, potentially no payment.
Okay, crystal clear on the documentation front. Now, let's get into the specifics of how reimbursement actually works in different healthcare settings. Let's start with hospitals, both for patients who are admitted, the inpatients, and those just coming in for outpatient services.
Okay. So, hospital inpatient care is reimbursed under what's called the Inpatient Prospective Payment System, or IPPS. Just to give you an idea, back in 2015, payments under this system totaled a very substantial $112 billion.
Wow.
Under IPPS, Medicare covers a beneficiary for up to 90 days of care per episode of illness, and there's also an additional 60-day lifetime reserve they can tap into. Each time a patient is discharged from the hospital, that discharge is assigned to a specific Medicare Severity DRG, or MS-DRG. This assignment is based on the patient's ICD-10 diagnosis codes and any procedure codes from their stay. The hospital then receives a predetermined lump sum payment for that specific MS-DRG. And crucially, this single payment is intended to cover all the care, products, and devices used during that entire inpatient stay.
So this system really creates an incentive for hospitals to manage patient care efficiently and cost-effectively, doesn't it? If they can provide the care for less than the lump sum, they keep the difference.
Exactly. That's the core idea of a prospective payment system. And CMS is increasingly tying these payments to the quality of care provided through various programs.
Like what kind of programs?
Things like the Hospital Readmissions Reduction Program, which penalizes hospitals with high rates of patients coming back soon after discharge. There's also the Hospital Value-Based Purchasing Program, which offers incentives based on performance on quality, safety, and patient satisfaction measures. And then there's the Hospital Acquired Condition Reduction Program, which penalizes hospitals with high rates of avoidable complications like falls or certain infections.
And wounds play a role in these quality programs.
They do. Specifically, stage 3 and 4 pressure ulcers and certain surgical site infections that develop while the patient is in the hospital are considered hospital-acquired conditions, or HACs, under that program.
Yeah.
It's also interesting. Back in 2008, CMS actually stopped providing additional payments to hospitals just because a patient had a stage 1 or stage 2 pressure injury that was already present when they were admitted.
So they don't get paid extra for treating those less severe pre-existing pressure injuries.
Right. And the financial impact of that particular change was actually significantly larger than the impact of not paying extra for the more severe stage 3 or 4 pressure injuries that developed in the hospital. So this really, really highlights the importance of accurately documenting whether any pressure injury, or a surgical site infection for that matter, was present on admission. That POA status is critical for hospital reimbursement.
Okay, that covers inpatient. Now let's switch to hospital outpatient centers. How does reimbursement work for services provided there? Is it similar?
It's different. Outpatient services are reimbursed under the Outpatient Prospective Payment System, or OPPS. This has been in place since August 2000, following the Balanced Budget Act of 1997.
OPPS, okay.
Under this system, outpatient services are grouped into what are called ambulatory payment classifications, or APCs, and each APC has an established payment rate associated with it.
APCs, ambulatory payment classification.
Exactly. The CPT codes that are used to identify the specific visits and procedures performed during the outpatient encounter are then mapped to these APC groups. The groups are designed to include services that are similar in terms of their cost to provide. The Part B Medicare Administrative Contractor, the MA, then pays the hospital a predetermined amount for the assigned APC group. And similar to the inpatient side, this payment is intended to cover all the necessary supplies used during that outpatient visit, including things like wound dressings.
So dressings are bundled into the outpatient payment.
Generally, yes. And it's also interesting to note that since 2013, CMS has bundled the payment for those cellular and tissue-based products, the CTPs used for skin wounds, into the facility fee for the procedure where they're applied. And CMS is currently considering other potential payment methods for these CTPs, possibly moving towards something like an episode of care payment model in the near future. Maybe as early as 2020 was the target mentioned in our sources.
Interesting. And do patients pay anything for outpatient services?
Yes. Patients typically have a coinsurance payment, which is usually 20% of the Medicare allowed amount after they've met their annual Part B deductible for outpatient services. This coinsurance amount can also be adjusted based on geographic wage variations across the country.
Okay, let's move on now to skilled nursing facilities, or SNFs. Medicare Part A provides coverage for a limited stay in these facilities, but under specific conditions, right?
That's correct. Medicare Part A can cover up to 100 days in a skilled nursing facility per benefit period. But there are pretty specific eligibility rules.
Like,
Usually, it includes having had a recent prior hospital stay of at least 3 consecutive days. The patient needs to be admitted to the SNF within 30 days of that hospital discharge. And crucially, they must need skilled nursing or therapy services on a daily basis for a condition that is related to the reason for their hospital stay.
got it. And how are SNFs paid?
Since 1998, SNFs have been paid under their own prospective payment system, or PPS. Under this system, SNFs receive a daily payment rate, a per diem rate. This rate is adjusted based on the patient's case mix, which essentially reflects the complexity of their care needs, and it's also adjusted for geographic variations in wages. Now, this per diem PPS rate is intended to cover almost all the services a patient receives while they're in the SNF. That includes things like room and board, nursing care, therapies, but also wound care supplies, specialized therapies for wounds, and even support services like specialized beds or mattresses.
So pretty much everything is bundled into that daily rate.
For the most part, yes. And some argue that this bundled payment system could potentially limit the incentive for SNFs to use more expensive or highly specialized wound care treatments, since they don't get paid extra for them during that Part A covered stay.
That makes sense.
And it's also important to remember that during those first 100 days covered under Part A, the SNF cannot separately bill Medicare under Part B for services like physician visits or certain supplies. That can only happen after the Part A coverage period ends.
Long-term care facilities like SNFs are also subject to a significant amount of regulation, aren't they? It's not just about payment.
Oh, yes, definitely. Skilled nursing facilities that participate in Medicare and Medicaid are required to comply with a really comprehensive set of federal and state regulations. CMS actually revised its guidelines back in November 2017, placing an even greater emphasis on the accurate identification of wounds and the development of comprehensive care plans for any resident who has a wound. The regulations specifically addressing pressure ulcers are particularly extensive. They focus heavily on prevention strategies, ensuring appropriate treatment protocols are followed, and actively working to prevent the development of new pressure ulcers while a resident is in their care.
And what happens if they don't comply?
Failure to comply with these regulations can result in pretty significant penalties for the facility. These can range from monetary fines to withheld payments, or in severe cases, even potential closure of the facility. So compliance is a very big deal.
Our sources also discuss something called the Resident Assessment Instrument, or RAI, and the Minimum Data Set, often called MDS 3.0. What are these, and how do they relate to wound care in SNFs?
Okay, so CMS requires all skilled nursing facilities to complete a standardized assessment on every single resident. This assessment is known as the Resident Assessment Instrument, or RAI. The main purpose is to help improve the quality of care provided by gathering consistent information.
Okay, a standardized assessment.
Right. And a key component, really the core of the RAI, is the Minimum Data Set, or MDS 3.0. This is a very comprehensive assessment form. It has over 400 items.
Wow.
It assesses a resident's functional abilities, their cognitive status, continence, various medical conditions, and, importantly for our discussion today, their skin condition. This assessment has to be completed when a resident is first admitted, then at least quarterly, and also whenever there's a significant change in their health status.
And it specifically looks at wounds.
Yes. Section M of the MDS 3.0 is specifically focused on skin conditions. It collects detailed information on various types of wounds: venous ulcers, arterial ulcers, burns, skin tears, surgical wounds, moisture-associated skin damage.
Okay.
And it also has 9 specific subsections that drill down just on pressure ulcers. These look at the resident's risk of developing them, the number of pressure ulcers they currently have at each stage of severity, the type of tissue involved in the most severe one, and whether any existing pressure ulcers have actually worsened since the last assessment.
So very detailed on pressure ulcers.
Very detailed. And the MDS 3.0 uses the staging system developed by the National Pressure Injury Advisory Panel, which includes those categories for deep tissue injury and unstageable pressure ulcers. It also focuses more on describing whether a wound is healing rather than using the old concept of reverse staging, which isn't really accurate.
Right.
The data collected in the Section M can actually trigger specific care planning actions related to addressing pressure injuries, as well as ensuring the resident's nutrition and hydration needs are met, since those are closely linked to wound healing. The overall goal is to better link the assessment data to the resident's quality of life, incorporate the updated pressure ulcer staging, and make sure that care planning is based on current best practices and evidence.
And this detailed assessment data collected through the MDS is then used to determine how the skilled nursing facility actually gets paid, right? Through something called Resource Utilization Groups, or RUGs.
Exactly. The data collected through that RAI, primarily the MDS, is directly linked to Medicare's skilled nursing facility payment system through a case mix classification system called Resource Utilization Groups, or RUGs.
RUGs.
Right. So the prospective payment system uses these RUGs to create that per diem payment rate we talked about, the one that covers most of the services provided in the SNF, including wound care. Residents are assigned to one of 66 different RUG categories based on the information in their MDS assessment. This reflects their specific characteristics and the amount and type of therapies they receive. Each RUG category is designed to group residents who are relatively similar or homogeneous in terms of the resources they are likely to need. These categories include broad areas like rehabilitation services, residents needing extensive care, those needing special care, which often includes significant wound care, and those with clinically complex conditions.
Okay.
The payment rates for each RUG are calculated separately for urban and rural areas, and they're also adjusted to reflect local labor market conditions using a wage index.
So accuracy in that MDS assessment is critical for payment.
Absolutely essential. Accurate and timely completion of the MDS is crucial for SNFs to receive the correct payments. Residents who require more intensive care based on their MDS assessment are classified into higher-paying RUG categories. Conversely, failure to complete the MDS accurately or on time can lead to lower default payment rates or, in some cases, even no payment at all for that period.
And this system is also evolving, isn't it?
Yes. CMS has been in the process of updating the SNF PPS. There's a greater emphasis now on value-based purchasing, with potential penalties and bonuses related to preventing hospital readmissions from the SNF. And importantly, they've been implementing a new patient-driven payment model, or PDPM, which is designed to replace the RUG's system.
PDPM, patient-driven payment model.
Right. The goal of PDPM is to focus more on the resident's clinical characteristics and their specific care needs, rather than basing payment primarily on the sheer volume of therapy services provided, which is a criticism of the RUG system.
Okay, that makes sense. Let's now turn our attention to home health agencies, or HHAs. Medicare also provides coverage for certain skilled healthcare services delivered right in a patient's home.
Yes, that's another important setting. Medicare covers skilled nursing care, home health aid services, physical therapy, occupational therapy, and speech therapy for beneficiaries who meet certain criteria. Generally, they need to be considered homebound, meaning it's difficult for them to leave home, and they must require part-time or intermittent skilled care.
Hmm.
Since October 1st, 2000, home health services have been paid under their own prospective payment system, or PPS. Payments are made in 60-day episodes of care. Patients are assigned to one of 153 home health resource groups, or HHRGs.
HHRGs, home health resource groups.
Exactly. This assignment is based on their clinical and functional status, which is determined using another standardized assessment tool called the Outcome and Assessment Information Set, or OASIS, and also based on the amount of services they're expected to use during that 60-day episode.
Okay. And how does reimbursement for wound care fit into this home health model? Are supplies covered?
Well, the base payment rate for these HHRGs is adjusted geographically, and it does include reimbursement for routine and non-routine medical supplies used during the home visits.
Okay.
However, that HHRG payment generally does not include separate payment for things like drugs, biologics, or most durable medical equipment. That includes most traditional negative pressure wound therapy, NPWT pumps, and pressure-relieving devices like specialized beds or mattresses. Those are typically billed separately under the de-imposed benefit.
But wasn't there a change regarding disposable NPWT?
Yes, that's an important exception. Since 2017, there's been a separate payment mechanism specifically for home health agencies to be reimbursed for providing disposable negative pressure wound therapy devices under the home health benefit. This change came about through the Consolidated Appropriations Act of 2016.
Ah, okay. So they get paid separately for those now.
Right. These disposable MPWT devices are billed using specific CPT codes based on the size of the wound being treated. There's code 97607 for wounds 50 square centimeters or less, and 97608 for wounds larger than 50 square centimeters.
Mm-hmm.
The payment for these services and the disposable device itself is actually made under the Hospital Outpatient Prospective Payment System, HOPPS rates, and it's subject to the usual area wage adjustments. CMS even issued a specific MedLearn Matters article to provide guidance to HHAs on how to bill for these services correctly.
And is the home health payment system also changing?
Yes, similar to the SNF changes, CMS has proposed revisions to the Medicare Home Health PPS. They introduced the Patient-Driven Groupings Model, or PDGM.
PDGM, Patient-Driven Groupings Model.
Right. The goal here is similar to the SNF changes to remove potential incentives for over-providing therapy services just to get higher reimbursement, and instead rely more heavily on the patient's clinical characteristics to determine payment. They also shifted to a shorter 30-day unit for payment episodes instead of the older 60-day model.
Okay. You mentioned OASIS earlier. What is the OASIS C2 form, and why is that so important for home health agencies?
The OASIS C2 form is that standardized assessment tool that's required every time a Medicare patient receives home health services. It's really comprehensive. It serves multiple purposes. It provides the foundation for developing the patient's individualized plan of care. It's used for measuring patient outcomes in a risk-adjusted way so you can compare performance across different agencies. And crucially, it's used for determining the payment under the prospective payment system we just discussed.
Sure.
The current version is OASIS C2. It was implemented back in 2017, partly to align with the standardized post-acute care quality measures required by the IMPACT Act, the Improving Medicare Post-Acute Care Transformation Act.
IMPACT Act.
Right. The OASIS C2 collects a wide range of information: socio-demographic factors, the patient's living environment, their available social support, their overall health status, and their functional abilities. This data really forms the basis for the care plan.
And does it track wounds specifically?
It does. It collects quite detailed information on all pressure injuries the patient might have. However, it collects more limited data on other types of wounds, like stasis ulcers or surgical wounds.
Okay. When does this assessment get done?
It's completed at several key time points. When the patient is first admitted to home health services, then at least every 60 days while they're receiving care, when the patient is discharged from home health, and also anytime the patient experiences a significant event like a hospitalization.
Hmm.
The data collected through OASIS C2 is then used for the Home Health Quality Reporting Program. This program tracks various quality measures, including both process measures, like whether certain assessments were done, and outcome measures. The outcome measures are risk adjusted to account for differences in patient populations and include things like rates of improvement in walking ability, the occurrence of potentially avoidable events like falls, and the patient's utilization of hospital or emergency services.
So accuracy is key here, too.
Absolutely essential. Accurate assessment by the home health clinicians completing the OASIS is critical. While some studies looking at the reliability and validity of OASIS C2 have shown results in the sort of low to moderate range for consistency between different assessors, proper training of clinicians can definitely help to improve accuracy. And finally, home health agencies are required to transmit all this OASIS C2 data electronically to CMS. If the form isn't completed properly as submitted correctly, it can lead to significantly lower Medicare payments for the agency, or potentially even no payment at all for that episode of care.
Okay. Let's finally discuss how physicians' offices and other qualified health practitioners, or QHPs, are reimbursed for providing wound care services. How does that work?
Right, so Medicare pays for the services provided by physicians and other qualified health practitioners. That includes nurse practitioners, physician assistants, clinical nurse specialists, based on the Medicare Part B physician fee schedule.
Okay, the physician fee schedule.
Exactly. They are essentially paid for each individual service or procedure that is deemed medically necessary and is properly documented in the patient's medical record. This covers things like office visits, minor surgical procedures performed in the office, and various diagnostic and therapeutic services related to wound care.
Mm-hmm.
The fee schedule itself is this comprehensive list. It contains around 7,400 covered services, along with the specific payment rate assigned to each one. These services are classified and reported using those HCPCS codes, mainly the CPT codes that we discussed earlier.
And how are those payment rates determined?
The rate determination is pretty complex, but it essentially takes into account three main factors: the amount of work required by the practitioner to perform the service, the practice expenses involved in providing that service, like staff, supplies, office space, and the cost of professional liability insurance or malpractice insurance.
Got it.
Generally, for most services on the fee schedule, Medicare pays 80% of the allowed amount, and the beneficiary is responsible for the remaining 20% as coinsurance after they've met their annual Part B deductible. These payment rates are also adjusted based on geographic location to account for variations in practice costs across the country.
Okay.
Mm.
Reimbursement and the quality of the care delivered are clearly very, very closely linked throughout this whole system. Our sources spend some time discussing various quality improvement efforts, specifically in the realm of wound care.
Absolutely. You really can't separate reimbursement from quality assessment and improvement anymore. As we've touched on, if the care provided is deemed substandard, it might not get reimbursed. And if errors occur that lead to patient harm during treatment, that could even potentially lead to allegations of fraudulent billing.
Right.
But beyond just the punitive measures, CMS also uses a variety of initiatives to try to actively improve the quality of care. Many of these initiatives, at least historically, have focused quite heavily on pressure injuries, and these efforts could potentially serve as a model for how to address quality improvement for other types of wounds as well.
What are some of the main ways that quality measurement is being used to try and drive these improvements in care?
Well, our sources highlight about 4 key approaches. The first one is about empowering consumers.
Oh, so.
By providing them with information about the quality of care provided by different facilities and providers. Think about websites like CMS's Home Health Compare or Nursing Home Compare. These sites publish performance rates on various quality measures and use things like a 5-star rating system to help consumers make choices.
Mm-hmm. Does it work?
Well, the actual impact of this public reporting on driving significant care improvement is still being studied. It's not entirely clear yet.
Okay. What's the second approach?
The second approach involves formal quality improvement activities, often called QI or QAPI, quality assurance and performance improvement. This is where healthcare organizations systematically use their own data to identify and understand problems in care delivery and then implement changes to fix them. Most provider organizations are involved in these kinds of activities to some extent. And performance feedback, for instance, has been shown to help reduce hospitalizations in the home care setting.
Okay. And the third?
A third approach is through more detailed analysis of individual patient care. For example, hospitals that get flagged for having high rates of pressure ulcers based on indicators like those used in Hospital Compare might have individual patient cases reviewed more closely.
Right.
Similarly, state surveyors who inspect nursing homes often focus specifically on the facility's prevention and treatment of pressure ulcers and whether they're complying with regulations. Often, the cases they look at are identified through quality indicators derived from that minimum data set, the MDS.
Got it. And the fourth approach.
Finally, there is that growing emphasis we talked about earlier on pay for performance and value-based purchasing. This is the idea of giving healthcare providers higher reimbursement for delivering better quality care.
Hmm.
Now, theoretically, this should be really effective, but the current data, particularly from areas outside of wound care, has been somewhat mixed. There are questions about whether the incentive amounts are large enough to really drive change, whether financial rewards are always the best change agent, and also ongoing challenges with accurately measuring quality in a meaningful way. Nursing home demonstration projects exploring pay for performance are still in their relatively early stages, and the extent to which they specifically focus on wound care outcomes is not yet fully clear.
So the act of measuring quality itself is really fundamental here. As the old saying goes, if you don't measure quality, you can't improve it.
Exactly. And the good news is there's a potential wealth of data available in those big CMS databases, MDS 3.0 from nursing homes, Oasis C from home health, and now the more detailed ICD-10 codes from hospital claims. These databases contain patient-specific information that can be used to look at both the processes of care, what was done, and the outcomes achieved, what happened to the patient.
Mhm.
ICD-10 coding, in particular, is much more informative than the old ICD-9 system for analyzing hospital data. However, there are still ongoing concerns about the potential for undercoding or maybe misstaging pressure injuries, which could skew the data.
Right.
CMS does disseminate various quality measures that are specific to different care settings. For example, nursing home compare reports on the rates of new or worsened pressure ulcers for short-stay residents, and also the percentage of high-risk long-stay residents who have pressure injuries.
And are these measures becoming more consistent across settings?
Yes, there's definitely a trend towards standardizing these measures. For instance, nursing home compare, long-term care hospital compare, and inpatient rehabilitation facility compare all now report on new or worsened pressure injuries using similar definitions. And hospital compare includes pressure ulcer rates as part of its overall complication measures.
But you mentioned criticisms of these measures.
Yes, the use of these publicly reported measures hasn't been without criticism. There are concerns about the quality of the underlying data, especially when relying solely on ICD codes. We know from clinical studies that the actual rates of pressure injuries are often much higher than what was captured using the less specific ICD-9 codes. The positive predictive value of some measures, meaning how likely it is that a flagged case actually represents poor quality, can be limited, although it's potentially improving with the use of that present on admission, POA coding, and the greater specificity of ICD-10. There's also this ongoing debate about the need for better risk adjustment. Differences in reported performance between facilities might simply reflect differences in the types of patients they serve. Some might have sicker, more complex patients who are inherently at higher risk.
Right. Comparing apples and oranges, potentially.
Exactly. And some studies have even shown a poor correlation between these reported quality measures and what's actually observed in terms of care delivery, or even with successful quality improvement efforts undertaken by the facility. So the measures aren't perfect.
But they are being used.
They are. And despite these limitations, many other wound care quality measures do exist. Organizations like the National Quality Forum, NQF, have reviewed and endorsed various measures. For example, the Assessing Care of Vulnerable Elders, or ACOV project, developed specific quality indicators for pressure injuries using simple if-then statements to define what constitutes quality care in certain situations.
And these quality measures are now directly tied into how qualified health professionals are being paid through that new MIP system we discussed.
That's correct. That new Medicare payment system for QHPs, physicians, nurse practitioners, etc., which started back on January 1st, 2017. The majority of these professionals are now subject to MIPs.
Right. The merit-based incentive payment system.
Yes, and they get a composite score from 0 to 100 based on their performance in those 4 categories. Reporting quality measures, participation in clinical practice improvement activities, CPIAs, their use of interoperable electronic health records, what used to be called meaningful use, and the cost or resource use associated with the care they provide. This composite score then determines their payment adjustment status for their future Medicare Part B billings. They could get a bonus, face a penalty, or just have a neutral adjustment.
And it's budget neutral, you said.
Right. MIPS is designed to be budget neutral, meaning that the money for the bonus payments comes directly from the penalties applied to lower performing clinicians. The goal over time is also to increase the importance of the cost component in determining the final score.
How did it go in the first year?
Well, the initial year of the program had some exemptions and transition rules that limited the maximum potential bonus quite a bit. This maybe reduced the immediate financial incentive for clinicians to fully participate right out of the gate. However, the potential penalties are set to increase in later years, which should motivate more providers to at least achieve a minimum score to avoid being penalized.
And how can clinicians improve their MIC score, especially regarding wound care?
Success in MIs, particularly in the quality category, can often be increased by participating in a qualified clinical data registry, or QCDR.
UCDR, Qualified Clinical Data Registry.
Exactly. These are CMS-approved entities that collect clinical data for the purpose of tracking patients and improving care. The U.S. Wound Registry, or USWR, is an example of a registry that has been approved as a MIPS registry specifically for wound care. The quality measures it tracks are listed on its website. Now, one barrier that's been noted is the reluctance of some electronic health record, EHR, vendors to incorporate the necessary programmatic language to easily report these wound care-specific quality measures, perhaps due to the limited early bonus money available in MAPs.
Technical challenges.
Yeah, but the data we do have shows that even reporting on very basic process measures like whether diabetic foot ulcer patients receive appropriate offloading or whether venous leg ulcer patients receive adequate compression therapy, even tracking those basics can lead to improved healing rates.
Interesting.
There are also efforts to establish benchmark healing rates using tools like the Wound Healing Index to try and create a more level playing field for comparing outcomes between different providers and to demonstrate the impact of quality improvement efforts over time. The USWR has also developed specific clinical practice improvement activities, or CPIAs, related to wound care. This allows providers who might focus on wound care but perhaps struggle to report the quality measures to still participate actively in MS and potentially avoid penalties.
So beyond these broad quality measurement systems and payment incentives, what specific efforts are being made to actively help healthcare providers manage and improve the care they deliver to patients with wounds?
Well, beyond the more general approaches we've discussed, CMS also promotes specific quality improvement initiatives for Medicare beneficiaries through contracts with organizations known as Quality Improvement Organizations, or QIOs.
QIOs, Quality Improvement Organizations.
Right. These are typically non-governmental organizations that contract with CMS regionally or nationally to help implement evidence-based practices. They often use methods like learning collaboratives, bringing groups of providers together to work on shared problems. These collaboratives frequently focus on specific conditions or patient populations, with a strong emphasis on improving patient safety and achieving better health outcomes. In the field of wound care, the primary focus of these QIO efforts historically has been largely on preventing and treating pressure injuries.
Can you give some examples?
Sure. For instance, organizations in New York developed toolkits specifically for hospitals to use to improve pressure injury care. In 3 other states, QIOs train teams from various nursing homes on quality improvement methods and specific best practices for pressure injury care, and they provided ongoing mentoring to those teams. Another example is a collaborative effort led by the New Jersey Hospital Association, which involved multiple hospitals working together and reportedly resulted in a significant reduction in their overall hospital-acquired pressure injury rates.
And are other agencies involved besides CMS and the QIOs?
Yes, other government agencies like the Agency for Healthcare Research and Quality, or AHRQ, also promote non-regulatory initiatives aimed at improving skin care. For example, AHRQ developed a comprehensive hospital pressure injury prevention toolkit that emphasizes the importance of organizational readiness and culture change. They also created a clinical decision support instrument specifically for nursing homes that, when implemented, has been shown to help reduce the incidence of pressure injuries.
And is there solid evidence to suggest that these various improvement efforts, whether regulatory or non-regulatory, are actually making a tangible difference in outcomes?
Yes, the evidence really does indicate that these multifaceted efforts are having a positive impact, particularly on pressure injury prevention. Many hospitals across the country have reported significant reductions in the rates of hospital-acquired pressure injuries over the past decade or so.
Mhm.
For example, our sources mentioned the CLNOC registry, that's the Collaborative Alliance for Nursing Outcomes, which includes data from 78 hospitals just in California. Their data showed a really substantial decline in hospital-acquired pressure injuries, dropping from about 10.4% back in 2003 down to just 1.8% by 2010. That's a huge improvement.
Wow, that is significant progress.
Yeah.
So to try and summarize this incredibly complex world of wound care regulations and reimbursement that we've been navigating.
Well, I think the main takeaway is that regulatory agencies are undeniably major players in the wound care field. And as the healthcare system continues to focus more and more on cost effectiveness, we're likely to see even more complex regulations emerging that affect how wound care gets reimbursed.
Mhm.
The absolute key to providing optimal wound care within this intricate system and getting paid for it really comes down to good documentation. It needs to clearly articulate the medical necessity for the services and products being used, detail the patient's assessment findings, describe the interventions provided, and, crucially, document the outcomes achieved.
Right.
This comprehensive documentation not only benefits the patient by ensuring their care is well planned and tracked, but it also benefits the healthcare provider by justifying payment, and it benefits the regulatory agencies by providing transparency and accountability.
Our sources even provide a helpful little patient scenario at the end to illustrate some of these financial implications in a real-world context. It involves a gentleman named Mr. Y. He's 72, a resident of a long-term care facility, and he gets admitted to the hospital for pneumonia. He also happens to have a stage 3 sacral pressure injury that he actually developed back in the long-term care facility before coming to the hospital.
Yes, this scenario really drives home the financial importance of accurately documenting those conditions that are present on admission, or POA.
Good.
In Mr. Y's case, the problem was that while the nursing staff had documented the stage 3 pressure injury in their notes when he was admitted to the hospital,
Mhm.
the admitting physician had not included it in his official admission documentation. Now, because of those Medicare reimbursement changes that took effect back in October 2008, hospitals generally don't receive additional payment for treating certain hospital-acquired conditions, and that now includes stage 3 and 4 pressure ulcers.
Okay.
Now, Mr. Y's pressure ulcer was present on admission. It wasn't hospital-acquired. But because it wasn't documented as such by the physician initially, the hospital risked losing the higher reimbursement associated with the DRG that would typically include a secondary diagnosis reflecting the severity and cost of treating a stage 3 pressure injury.
Wow, so a documentation oversight could cost the hospital real money.
Exactly. It was only when the hospital's coder, who reviews the charts for billing, noticed this discrepancy between the nursing notes and the physician documentation, and then queried the physician about it, that the physician confirmed the pressure injury was indeed present on admission and amended his documentation accordingly. Only then could the coder submit the claim accurately for the appropriate, higher level of billing. It really underscores just how significant the financial implications of accurate and timely POA documentation can be.
That's a great illustration.
Mm-hmm.
Well, our deep dive today has certainly illuminated the incredibly complex and sometimes confusing web of regulations and reimbursement that surrounds wound care in the U.S.
Yeah.
It's a lot to keep track of.
It really is. It's constantly evolving, too.
So thinking about all this intricacy, all these moving parts, what role do you foresee technology and maybe innovation playing in potentially simplifying or at least improving wound care regulation and reimbursement in the years to come?
Right.
Is there hope for streamlining this? It's definitely something for us and for you, the listener, to consider.